All right, so we will get started. Thank you all for coming. I'm Margaret Pulley. I am at the University of Rochester. It's my first year as faculty, and on behalf of the Guideline and Evidence-Based Medicine Subcommittee, I welcome you to this session, the 10 most important papers in CL Psychiatry for the 2022-2023 academic year. And so this presentation, which we've done a couple years now, what happened? Okay, we good? All right. So we've done this session a couple of times, and so this comes out of one of the main things that the subcommittee does, which is the annotated articles that are on the ACLP website. So there are a lot of different subtopics. People review articles throughout the year, and then they put summaries of articles that are relevant to all different areas of CL Psychiatry on the website. And it's a really wonderful resource, and definitely suggest checking that out. So from that, we selected 10. And the way that these were selected is they were nominated by members of the committee, and then we held a vote. And the top vote getters are the ones that we're presenting to you today that we feel are particularly relevant, interesting for general CL practice in the next year. All right. And now Dr. Sarah Andrews will present the first articles.
Hi, I'm Sarah Andrews, and I'll be discussing two of recent articles that have had significant impact in the field of consultation-liaison psychiatry focused on transplant population. I have no relevant disclosures. The first article is entitled Racial and Ethnic Disparities in Psychosocial Evaluation and Liver Transplant Waitlisting. The article was published in the American Journal of Transplantation in June 2023 by Dutch Link and colleagues. The objective of the study was to investigate potential racial ethnic inequities within the liver transplantation waitlist process. Data was gathered from a psychosocial evaluations and the Stanford Integrated Psychosocial Assessment, the SIPAT. The cohort consisted of 2,271 candidates evaluated for liver transplant between 2014 and 2021. Results demonstrated there was no significant associations between race and ethnicity and overall waitlisting, and not waitlisting for medical reasons. However, Black race and Hispanic and Latinx ethnicity compared to white race was associated with not waitlisting for psychosocial reasons. Underlying racial and ethnic disparities in liver transplantation are multifactorial and have been previously well described in the literature in regards to referral, waitlisting, as well as post-transplant outcomes. These disparities include social determinants of health and structural racism, all of which can lead to economic hardship, food insecurities, inadequate housing, poor transportation options, discrimination, and unequal access to education. All of these issues have effects on health literacy as well as health outcomes. Rosenblatt and colleagues recently reported that Black patients were least likely to receive a liver transplant, specifically 27% less likely to be listed and 20% less likely to have a transplant compared to white patients after adjusting for mortality. The study by Dutch Link and colleagues aimed to build on the growing research of race and ethnicity disparities to better understand the mechanisms underlying these inequities and identifying possible targets to improve access. The aims included to investigate differences in psychosocial factors across race and ethnicity, to examine racial and ethnic disparities in overall waitlisting, to investigate differences for not waitlisting, and lastly, to investigate whether psychosocial factors unequally affect different racial and ethnic groups in access. This was a single center cohort study from a large urban transplant center. All patients underwent a comprehensive medical and psychosocial evaluation, which involved the SIPAT, which is a psychosocial assessment used in transplant evaluations. The SIPAT includes 4 domains, including knowledge and readiness towards transplant, which also includes health literacy, understanding of disease, and treatment compliance, social support system, psychological stability, and psychopathology, and lastly, lifestyle behaviors, including substance use. A multidisciplinary selection committee determined all waitlisting outcomes. The exposure variable within the study was race and ethnicity, which was self-reported. The covariate was the SIPAT score, which ranges from 0 to 119, and higher scores reflected higher psychosocial risk. Other covariates included sex, age, liver disease etiology, primary insurance, level of education, zip code, and model for end-stage liver disease, the MELD score at evaluation. Outcome was measured by transplant waitlisting. For the statistical analysis, SIPAT scores were divided into two groups. Less than 21 represented a good or excellent candidate, and 21 was a minimally acceptable candidate. Each SIPAT domain was also converted to a binary variable. Patient characteristics were separated by race and ethnicity. Of the patients evaluated, 64% were men. Most patients self-identified as white as 74%, followed by Black, 14%, and Hispanic and Latinx at 6.5%. Among all patients, the median SIPAT score was 15. 30% of patients received a SIPAT score of 21, which was a minimally acceptable candidate. Median total SIPAT scores were highest in Hispanic and Latinx patients, followed by Black, white and other, and lastly Asian. Compared with white patients, Black patients showed a higher prevalence of high-risk SIPAT scores. Hispanic and Latinx patients were more likely than white patients to have high-risk scores in readiness as well as social supports. In regards to waitlisting outcomes, a total of 999, which was 44% of the candidates, were not waitlisted for liver transplant. Of those not waitlisted, 1/4 weren't waitlisted because their condition improved, a third due to medical reasons, 12% died during the evaluation process, and 16% were not listed due to psychosocial concerns. In a univariable analysis, Black race, Hispanic, Latinx ethnicity, alcohol liver disease, viral hepatitis, and each SIPAT domain score, as well as Medicaid insurance, was associated with not waitlisting due to psychosocial reasons. In a multivariable analysis adjusted for sex, age, and MELD, associations between Black race and Hispanic and Latinx ethnicity persisted. The predicted probability of not being waitlisted due to psychosocial concerns for Black patients with a SIPAT score of 21 was 43% compared to 23% for white patients. There was no difference in association between overall waitlisting and race and ethnicity in the multivariable models. There was no difference in failure to waitlist for medical reasons across race and ethnicity. The goal of the study was to investigate psychosocial factors across race and ethnicity that may impact liver transplantation waitlisting. Although no significant differences were determined in the overall waitlisting process, Black and Hispanic Latinx patients were more likely to be denied due to psychosocial reasons. Even though the difference in the total SIPAT scores were minimal, Black patients were more likely to be declined, lending itself to suggest that either not all elements are captured on the SIPAT or there's an implicit level of bias. The significant interactions between race, ethnicity, and psychosocial risk imply that Black and Hispanic Latinx patients may be more affected by psychosocial factors compared to white patients. This sheds light into the inequity in the waitlist access and complex negative effects of structural racism. Racism and implicit bias may also influence psychosocial resources and impact being labeled as a high-risk psychosocial transplant candidate. Some of the limitations of the study was that it was a single-center study. Referral patterns, as well as access to living donor transplants, were not explored in the study. Previous literature has shown that referrals for transplant are unequal across race and ethnicity, and that Black patients are less likely to be referred. This study contributes to the growing research on race inequity in liver transplantation. Transplant centers should aim to acknowledge the documented risks of racial bias in the psychosocial evaluation. And ongoing research is necessary to further understand racial bias within the transplant process. So the second article I will be discussing is entitled ACLP Best Practice Guidance, Evaluation and Treatment of Depression in Solid Organ Transplant Recipients. The article was published in the Journal of the Academy of Consultation-liaison Psychiatry by Zimbrian and colleagues. This study developed best practice guidance on depression in solid organ transplant recipients in collaboration with ACLP Transplant Psychiatry Special Interest Group, as well as the Guidelines and Evidence-Based Subcommittee. Depression is a common issue in transplant recipients, and the ACLP Transplant Psychiatry SIG reviewed current literature and from the literature proposed recommendations. And recommendations include that all transplant recipients be screened routinely for depression. If a recipient screens positive, a thorough clinical evaluation should be completed. If the evaluation reveals a diagnosis of a depressive disorder, treatment should be recommended as well as offered. Depressive symptoms are common among solid organ transplant recipients, and depression has been associated with worse outcomes post-transplant. Dew and colleagues' meta-analysis summarized 27 articles that found that depressive symptoms and disorders increase the relative risk of mortality by 65%. Despite the increased risk of mortality, the mechanism by which depression worsens outcomes post-transplant is still unclear. The aims of the consensus project was to include recommendations that were not covered by other society guidelines or best practice recommendations. The aims were to review the current literature about depression in transplant recipients, including screening, evaluation, treatment, as well as impact, to offer clinical guidance, and to support ACLP members in promoting excellent clinical care in transplant patients. A modified Delphi method, a formal group consensus process, was utilized to identify best practices. A group of 8 self-selected experts from Transplant Psychiatry SIG, as well as the ACLP Evidence-Based Medicine and Guidelines Subcommittee, worked together. The process first included a literature search with articles published between 2000 and 2020. The initial search resulted in over 12,000 articles, and eventually 146 were selected as relevant to the topic. From the article reviewed, the working group developed recommendation statements. A survey was sent out to an extended group of experts of 35, and this expert group was selected by the ACLP Transplant Psychiatry SIG from members who had published or presented in the field or who were active in SIG activities or meetings within the last 2 years. An 80% acceptance threshold were set for each of these recommendations to be used for the voting process. The recommendations were reviewed by the ACLP Guidelines and Evidence-Based Medicine Subcommittee members. The consensus recommendations were submitted and then subsequently approved by the ACL Board of Directors. 21 of the 35 experts responded to the survey, including both physicians as well as psychologists. The median experience working with transplant patients was 14 years, and 94% had been working clinically within the population within the year prior. There were several recommendations that were developed. First being that solid organ transplant recipients should undergo screening once in the first 6 months after transplant, second time 1 year post-transplantation, and then yearly after. And given the high rate of depressive symptoms in the population and the negative impact of depression post-transplantation, the recommendation is to screen all recipients. Second, the screening for depression should be done through the Patient Health Questionnaire, the PHQ-2, 8, or 9. The PHQ is endorsed by enough respondents to meet the consensus threshold. In review of the existing literature, both the HADS, the Hospital Anxiety Depression Scale, as well as the PROMIS, the Patient Reported Outcomes Measurement Information System, had been validated in the transplant population and are acceptable screening tools. Treatment for depression should be guided by a clinical assessment and not screening alone. If a transplant recipient screens positive for depression, the positive screen should then trigger a clinical evaluation, ideally by a clinician who has expertise within transplant psychiatry. If the clinical evaluation leads to a diagnosis of a depressive disorder, patients should be offered treatment. Based on the available data, the experts identified first-line antidepressants being sertraline, escitalopram, and mirtazapine. Although the consensus survey did not inquire about therapy modalities, research has shown that cognitive behavioral therapy as well as interpersonal therapy have been highly effective in treating depression in the transplant process. The best intervention for treating depression post-transplantation is to treat any pre-existing conditions. The last recommendation was that future research on depression should focus on understanding the availability of mental health treatment services, including the efficacy of these interventions. Research should also focus on better understanding the mechanisms of depressive disorders in this population. Based on the literature review and the expert responses, an algorithm was developed to screen and manage depression in transplant recipients. Ongoing prevention, as well as psychoeducation, are key elements, including treating pre-existing depression prior to transplant, as well as further developing coping skills, improving social supports, and encouraging physical activity. If a patient screens positive for depression post-transplantation, it's important to notify their current mental health clinician. If they don't have a provider, to make a referral to either a transplant mental health provider or a community health clinician. After completing a clinical evaluation, if a depressive disorder is present, treatment should be offered. The algorithm highlights the need for ongoing prevention as well as yearly screening. This guidance, which is the first practice guidance on the topic to date, provides reasonable and useful recommendations in the evaluation and treatment of depressive disorders in the transplant population. CL psychiatrists have an important role in recognizing and managing depression in the population. This guidance is to also help normalize depression and support clinicians to address and manage mental health concerns. There were some limitations to this study, as there are challenges in developing expert-led guidance. Grade clinical guidelines were not able to be developed to the topic because there was lack of level A and B evidence within this subject. As such, a modified Delphi method was utilized due to the low number of high-level evidence of studies in transplant psychiatry. As further guidelines are developed, flexibility should be in place regarding methodology in order to best fit the topic. In conclusion, this guidance hopefully will increase and improve access to transplant patients and appropriate mental health care. There you go.
All right, so first my disclosure slide. I own a very small amount of Doximity stock and now forevermore have to include a disclosure slide. The first paper that I'm going to present is Efficacy of olanzapine in addition to standard triplet antiemetic therapy for cisplatin-based chemotherapy, a secondary analysis of the J-FORCE randomized clinical trial by Abe et al. So why this paper? Dopamine antagonists are a commonly used category of antiemetic medications and include well-known medications such as metoclopramide, or Reglan, and prochlorperazine or compazine. As well, of course, antipsychotics are frequently used in inpatient medical settings for management of anxiety, agitation, or psychosis, whether it's related to delirium and their medical illness or primary psychiatric condition. Polypharmacy is a constant area of concern for us in psychiatry in both inpatient and outpatient settings, and medications which have 2 or even 3 indications in the same patient is a topic of interest. So the background for this particular article is that there are multiple trials that have previously shown olanzapine to be an effective addition to antiemetic prophylactic regimens in patients that are receiving chemotherapy. Less well established was whether there were patient or disease-specific or treatment-specific or disease-specific factors which influence the effectiveness of olanzapine. So the methods of this particular paper, it was a pre-planned secondary analysis of the J-FORCE trial, which was a large double-blinded placebo-controlled trial investigating the addition of olanzapine to the standard triplet antiemetic therapy in patients who were receiving cisplatin-based chemotherapy. So patients received either olanzapine, 5 milligrams, or a placebo once a day on days 1 through 4 after receiving chemotherapy. And the group allocation was adjusted for factors that included age, gender, and their cisplatin dose. Patients recorded their degree of nausea, the presence or frequency of vomiting, and the use of rescue medication from the time that they received their chemotherapy until 120 hours later. The primary endpoint was defined as complete response, which was no vomiting and no use of rescue medication in the delayed phase, so 24 to 120 hours after receiving chemotherapy. They also looked at complete response within what they called the acute phase, or 0 to 24 hours after. So this is table 1 from this study. It was a random study. There's not random allocation. So this is here mainly for background info. The most interesting part here is just the risk factors that they did break out. History of motion sickness, drinking habit, and history of morning sickness, which are all considered to put someone at higher risk of ongoing nausea and vomiting after chemotherapy. And to cut straight to the chase, olanzapine was effective at reducing nausea and vomiting across all of the patient and treatment groups examined in all of their analyses. So this adds to the literature that olanzapine really is quite an effective antiemetic in the context of chemotherapy. So then what are the conclusions for us as CL psychiatrists? Because although this is a pretty narrow paper in terms of the population, I think it has a lot that we need to think about. So if olanzapine is an effective antiemetic with a very broad evidence base, then we potentially can reduce polypharmacy in other patients if we factor in these non-psychiatric effects of our psychotropic medications when making treatment recommendations. What I have seen in general is that oncology and palliative care are quite aware of olanzapine being an effective antiemetic, but by and large, other specialties in the hospital are not. And so very frequently, we might be using olanzapine as a PRN for anxiety, agitation, sleep, delirium, and they are also on other antiemetics. Do they need to be on all of those medications, or could we be more parsimonious? So of course, the limitations are that it's unclear how much we can generalize these results to non-onc populations, or if there are implications for the efficacy of olanzapine in patients that are already on chronic antipsychotic therapy, which we really can't speculate about based on the current data. Okay, next paper. So this was antipsychotic medication use among older adults following infection-related hospitalization by Zhang et al. So why this paper? Antipsychotics, of course, again, are used very frequently in the hospital for acute management of agitation and delirium. Antipsychotics all have a black box warning for mortality in patients with dementia, and the general clinical consensus across multiple areas is to discontinue them as soon as possible when they are used in this context. but there's relatively little data on the trajectory of antipsychotic use after hospitalization. So in this case, this was a retrospective cohort study using a very large claims data set that stretched from 2004 to 2022. The study population was patients 65 plus who had a new dispense of an oral antipsychotic medication within 30 days of hospital discharge. So they were not on it prior to the hospital, they had a hospitalization, and it was dispensed after that hospitalization, and that they had been admitted for one of the infection diagnoses that they included in the criteria. So patients with prior psychiatric diagnoses of a psychotic disorder, a bipolar disorder, or depression were excluded from this study due to the possibility that antipsychotic use could be for their psychiatric condition. It also excluded patients that were discharged to a SNF due to lack of access to that medication data. Discontinuation of the antipsychotic was defined as a gap of more than 15 days following the end of a dispense of a prescription. Discontinuation rates were examined for haloperidol and for atypical antipsychotics. They did not look at other first-generation antipsychotics due to the fact that many of them are explicitly and usually used for nausea. All right. So this is the patient characteristics. The main thing I want to draw your attention to is that the patients receiving Haldol were notably older and a bit frailer. It's not completely clear why, but that was really the main takeaway of this table. And then in terms of the results, so for new haloperidol users, the medication was discontinued for 52.1% of patients at 30 days after hospitalization, and for 93.7% of them at 180 days. In contrast, for any new atypical antipsychotic users, the medication was discontinued only for 11.4% of patients at 30 days and 76.3% by 180 days. They did break down and look at individual atypical antipsychotics, looking separately at Abilify, olanzapine, Seroquel, risperidone, and then everything else, and all of the results were similar across those. So they did see a trend of increasing discontinuation rates over time. So a 5% increase in discontinue rates for Haldol if you looked from 2004 to 2022, looking at change over years. These are the Kaplan-Meier curves for discontinuation. See the atypical antipsychotics are in blue and the Haldol is in orange. So Haldol is being discontinued more often than the atypical antipsychotics and earlier. There are, of course, limitations here in terms of the accuracy and completeness of ICD codes and claims data. There's always going to be some fuzziness there. Claims data do not provide sufficient information to distinguish regular or scheduled medication use from PRN use. And of course, patients with psychiatric conditions were excluded. So the generalization of the findings is not always clear. But conclusions for us. A very significant number of patients started on antipsychotics during hospitalization are continued on them at discharge, sometimes for significant periods of time. And atypical and second generation antipsychotic medications are less likely to be discontinued than haloperidol. And then in part of that, haloperidol discontinuation increased over time, which may have tracked with awareness of the black box warning. But this trend was not observed for atypical antipsychotics, suggesting that awareness of the risks of these medications may not be as well appreciated. And speaking from my personal experience and opinion, it does seem, particularly with the very high rates of use of the atypical antipsychotics for depression and depression augmentation, as well as for really what psychiatric diagnosis isn't treated with those these days, the awareness of those as a problematic or a scary psychiatric medication is much lower. And so I think it's probably there is an aspect if someone comes out of the hospital on Haldol and a primary care physician may go, oh, this person doesn't need Haldol, but they're not going to have that same reaction to a second generation antipsychotic. And again, this is me editorializing, not the paper, but I think given the scale of the challenges with education of individual providers and the diversity of hospital settings and services over which this type of prescribing occurs, I think that quality improvement and systems approaches are probably required to reduce unnecessary antipsychotic use more than education aimed at individual providers. Okay, my last paper that I'm going to present. Patients with IBD want to talk about sleep and treatments for insomnia with their gastroenterologist by Salwin, Derimer et al. Okay, so why this paper? Of course, psychiatric symptoms in patients with chronic illness are common. That's why we exist as a specialty, because of the intersection of those things. Sleep symptoms are common and have many etiologies, including both medical and psychiatric factors. And patient attitudes towards care of their psychiatric symptoms and care preferences are important to us as CL psychiatrists, particularly as we think about how to expand access and develop new models of care in a time of essentially psychiatric healthcare shortage, which does not seem to be abating. So what are the methods of this study? This was an anonymous mixed methods online survey of patients with IBD that were treated at Dartmouth-Hitchcock Medical Center. They collected data which included the presence of active versus inactive disease, severity of disease symptoms, that's their IBD disease, as well as several measures of insomnia and dysfunctional beliefs and attitudes about sleep questionnaire, insomnia-related behaviors questionnaire. They also collected information about ways that the patients would be willing to be asked about sleep and insomnia treatments and settings in which they would be open to receiving treatment. And they asked open-ended questions, which they then analyzed using qualitative methods. So in terms of the results, this again is table 1. As you would expect, it is New Hampshire, so it's not a very racially diverse sample, but it did have a mixture of men and women, and Crohn's disease and ulcerative colitis were unsurprisingly both well represented here. And I will say there's a lot of IBD specific information in the article that I'm not presenting here because I think it's not as generally relevant. I'm focusing on the things that were a little more specific or more general, I think, to CL psychiatry in general. So 84.6% of the participants with clinically, apologies, I'm gonna go back. So half the patients reported clinically significant insomnia and half did not. 84.6% of participants with clinically significant insomnia endorsed at least one treatment option. So they could endorse multiple treatment options. So you can see that's why the bars don't add up to one total. But in terms of taking medication, meeting with a specialist multiple times, attending a workshop, doing an online class, taking a vitamin or a supplement, following a workbook or an app, people were variously open to all of these different things. In terms of communication preferences, 70.3% of participants thought that their IBD provider should maybe or definitely ask about sleep during routine visits, and 63.4% thought that their IBD provider should give them recommendations on improving their sleep. And it was something like less than 10% thought these questions should not be asked, had an opinion in that direction. And then of course, well, I shouldn't say of course, of the patients with insomnia, 78.3% wanted their provider to ask about sleep and 70.3% wanted to give recommendations, which I think makes sense. They are experiencing something that is causing them problems, so they would like help. In terms of the qualitative findings, 255 of the participants did complete the open-ended questions, and of those, a little over half had clinically significant insomnia. 73% of the patients made direct or indirect comments that directly endorsed a relationship between sleep and their IBD, i.e., I believe they're connected and both have a negative impact on each other, or I need a good night's sleep to have my IBD under control. So in terms of the qualitative analysis, this is part of the table that is in the article, mainly looking at barriers and facilitators to treatment. And I think these are statements that really resonate with a lot of us, especially in outpatient settings, but inpatient as well. In terms of lack of knowledge about options, about what is a clinically significant symptom and what can be treated. So patients said things like, treatment may be worse than the problem. I don't want to be on another drug. That was a pretty common feeling. I don't want to be on another medication. I didn't think there was a treatment. If I knew there was something other than drugs to help, I would be interested, as well as minimizing symptoms. I feel like everyone deals with it and some people have it worse. I have many more problems that have a higher priority. And then in terms of things that could facilitate care, statements like, if it was streamlined with other IBD treatments and I didn't have to start care with a new department was a thing that was expressed. I want someone who understands what IBD is and how it affects sleeping habits, and also statements about how IBD providers asking about sleep, they felt that that would be good and it helped normalize things. So more in terms of thinking about these barriers and facilitators to care as CL psychiatrists, so the themes of the barriers were lack of knowledge about insomnia, including its severity and its treatability in particular, concern about being on more medications on patients that are probably already on several medications, and then straight up logistical time and cost. And so these are direct quotes out of the article. Improved ease of access was reported by participants to be the most important facilitator for seeking insomnia treatment. And participants also wanted guidelines or recommendations on who to seek treatment with, often preferring an embedded provider. Participants also reported wanting to learn about or engage in sleep treatments with a provider who understands how sleep and IBD can affect one another. So in terms of conclusions, and like I said, I think this article, although it is about IBD patients, really says something very important about our relationship with the medical system as CL psychiatrists. Because although this paper studied patients with IBD, there are a number of findings which can generalize to really any outpatient subspecialty clinic, but particularly for patients that have a chronic illness of a type where their specialty clinic may feel like their primary medical home and the place that they are most comfortable in the healthcare system. So logistical hurdles play a significant role in patients' ability or willingness to seek care. Some of this can be overcome with embedded providers. However, as one of those providers at the University of Rochester in a specialty clinic, as well as having colleagues who do this, you can very rapidly become overwhelmed with need in that model. But I think even more than that, medical details influence the treatment of psychiatric symptoms, and this is true both in terms of physiology, patient sensitivity to seeing a new provider, as well as the medical culture in which they receive care. And patients are very sensitive to seeing a new provider who doesn't understand that specific medical experience. And I think this is a problem that is worsening as we become more specialized, not just in psychiatry, but as an entire field. Because I saw this dynamic as well in, for example, the multiple sclerosis clinic when I was a fellow, where these are patients that are receiving medications that are cutting edge, their care is very complicated, they have very complicated physical symptoms, and seeking out mental health care from someone who doesn't understand that, who says, oh, well, your neurologist handles like all of those things, even though their symptoms often span both domains, is alienating or not viewed as helpful. And so it highlights a very important role for us in CL psychiatry and a risk as all of our colleagues and our specialties become increasingly advanced and subspecialized. Oh, nope, still presenting this part, sorry. Dr. Close was originally going to be here, and so she was going to present this next part, and I'm presenting in her place, so I'm not actually done. Next up, honorable mention. So this is one of the two guidelines that we are highlighting for an honorable mention in this talk. The use of opioids in the management of chronic pain, synopsis of the 2022 updated U.S. Department of Veterans Affairs and U.S. Department of Defense clinical practice guidelines. So this is a guideline put out by the VA about the management of chronic pain. And so it is an update to the clinical practice guideline. It included a systematic evidence review and a multidisciplinary panel. And it offers a number of recommendations with varying degrees of strength. So there are 3 algorithms in the supplement in the guideline, which is lengthy, so we're not going to go through all of it, to help guide clinical decision making. There are some limitations, mainly that the guideline does prioritize the use of buprenorphine over agonist opioids, but doesn't clearly specify how this should be implemented and the quality of evidence for the use of buprenorphine, and to specify here specifically for chronic pain, not for treatment of opioid use disorder, which of course it is highly effective for that, is not particularly high. But in terms of what the guideline recommends, continued recommendation against the use of opioids in the daily management of chronic pain. If opioids are required, they recommend the lowest possible dose for the shortest duration. And the new recommendations to screen for behavioral health conditions, prior traumatic brain injury, and psychological factors such as pain catastrophizing before and during opioid treatment, to provide pre-operative opioid and pain management education and reduce post-operative opioid use. And again, that recommendation to use buprenorphine instead of daily use of full agonist opioids for pain. Okay, and now I am done. Thank you.
Right, I'm Sahil Manjal and I have no disclosures. So the first article I'm going to talk to you about is Racial Disparities in Psychiatric Decisional Capacity Consultations. This was published in Psychiatric Services earlier this year. So a little bit of background about decision-making capacity, and some of this may be very basic information for the audience here. It's the most common reason for psychiatric consultation in the general hospital. It relates to medical decision-making, and it can be determined by any physician, doesn't necessarily have to be a psychiatrist, although we get called upon quite frequently to do this. It is situation, decision, and time specific. And it all kind of depends on the context. It's the easiest thing you'll do or the hardest thing you'll do if you just change the context a little bit. So there is some subjectivity that creeps in, and that's going to be relevant to this paper that I'll be talking about. It can vary over the clinical course, and certain times can be ambiguous, and in the end turns out to be a clinical judgment. So there's 2 frameworks that we're well aware of. The 4 skills are also called as the Applebaum and Griso criteria, and that evaluates, if the patient is able to have a consistent choice, which the patient can communicate, understands the relevant medical information, appreciates the situation and the consequences, and is there a rational reason? And as you can imagine, the rationality, the implicit bias that providers can have can kind of creep into those assessments. And then the sliding scale model, which really talks about depending on the complexity of the situation, the threshold for capacity goes up. So certainly you don't really need to spend like 2 hours talking to the patient depending on what he or she wants to order off a menu. But certainly you really want to get a lot of details if the patient is refusing a life-saving procedure with very limited risk. So what are the challenges that comes about in these capacity evaluations? So really, it can turn out to be overly cognitive, especially when you're evaluating the risk and benefits and understanding the medical situation. To really get into the rationality or the reason why a patient is making a certain decision, you really need to imagine a person very different from yourself. And sometimes during these evaluations, we don't really fully attend to what are the patient's values, the affect and emotions behind those decisions. There's plenty of research done that kind of talks about the subjectivity that comes into these evaluations. There was a paper that was published that showed that 33% of CL psychiatrists came to the same conclusion in standardized scenarios. So there is a lot of subjectivity that goes in. And 1 in 5 physicians are not aware that their personal values do have an influence on these assessments. So with that background, so let's kind of go into the study question that the authors had here. So they examined disparity and biases by race ethnicity in the placement and outcomes of these capacity evaluations. So they assessed that in 4 domains. One is just the request for the capacity evaluation that was placed in the EMR. Then the capacity evaluation itself, which was completed by the CL Psychiatry team. Then was there an impaired capacity determination? And if there was a change in the treatment plan due to this impaired capacity determination. So they examined 181 capacity consultations, and this was an urban tertiary care medical center in New York City. And over a 2-year period from January 2018 to December 2019. And the assessments were conducted with the 4 skills model, the Applebaum and Riso framework, which we talked about, and didn't use standardized instruments, which is typical in clinical care settings. They used the Epic Slicer Dicer medical record self-service tool to kind of give them an input, what was the racial ethnic distribution of total hospital admissions during that time. So they can compare if there was any racial disparity. So this is a pretty stark finding that came out. So if you look at the Black population, so total inpatient admissions were 18%, but the amount of capacity consultations that were placed during that interval was 43%. So you can see there's a huge disparity here, and also in Hispanic, not as stark as Black patients. There were 21% of the total hospital admissions and 26% of the capacity consultations that were placed. Kind of going into a little bit more details, I put a couple of arrows here. The first one kind of talks about Black and patients and Hispanic patients have lower education levels, and that's important. I mean, because that could be one of the mediators, right? Because education is directly correlated with informed consent and decision-making capacity. And the other arrow, it's not surprising that half of these consultations were placed for people with neurocognitive disorder and delirium. So they had this figure in the paper, kind of the capacity cascade. So the first bar kind of talks about the 181 capacity consultations that were placed. They eventually ended up doing 130 of them, and that kind of makes sense, right? A lot of times when we get called to do these capacity evaluations, usually not a capacity question, it's usually something else, and sometimes just guiding the medical teams kind of gets you out of that capacity evaluation itself. So 130 were done by the CL team, and out of those, 95 patients, the determination that they lacked decision-making capacity. And a subset of those, 67, required an eventual change of treatment. So for the patients who the CL team made the assessment that they lack decision-making capacity, in univariable analysis, what stands out is that Hispanic patients were more likely that if they lacked capacity, there was no change in their treatment course. But when you kind of did more multivariable analysis, kind of accounting for patient education, age, psychiatric diagnosis, this wasn't significant, but there was certainly a signal there that kind of exposing the patient through the whole capacity evaluation, taking away their autonomy, there was a good number of patients that actually didn't change their treatment. So how is it relevant to us and general psychiatrists? Black Hispanic patients, Hispanic to a lesser degree than Black patients, underwent capacity assessments required by the primary medical teams at a disproportionately high rate. In their sample, I mean, this could be due to lack of power. There were no significant racial disparities in the outcomes of these capacity evaluations. And changes in the treatment plan, even though there was a signal for Hispanic patients, which was not significant once they control for other variables. It does have significant implications for worsening patients' vulnerability in healthcare system because, kind of taking away the autonomy of someone can certainly marginalize the individual even more, who certainly may be, distrusting the medical system to begin with, and can perpetuate this lack of trust in clinicians and the medical system. Also to note, most medical providers in this country are from white and Asian racial ethnic background, and certainly something to be mindful of with the implicit bias that providers can have when you're evaluating patients for these capacity evaluations. Now, talking about the weakness, it was certainly a single hospital, and the sample size was rather small. And the data did not really kind of go into a lot of details about spoken languages and identified race and ethnicities beyond the broad categories that they had. And the EPIC slicer dicer tool has low quality data. And they did not comment on the race ethnicity of the consulting medical providers as well as CL psychiatrists. And in their paper, they did talk about this no change after labeling somebody not having capacity as a negative outcome, which I don't fully agree with, because a lot of times it kind of leads to a cascade of identifying the surrogate decision maker, guardian, and a lot of times, the decision is such that, there's really no point in changing the treatment course. So there's a lot of variables that kind of fits in regarding that, depending on the jurisdiction somebody is in, and may not entirely be due to implicit bias. All right, so that was the first one. The second paper I'll be talking about is the association between pre-existing mental health disorders and adverse outcomes in adult intensive care patients, a data linkage study. So it's well documented, and in the presidential session this morning, there was a lot of talk about, patients with mental health disorders, they have worse outcomes, when it relates to physical comorbidities, mortality, all those sort of things. And a lot of that data comes out from outpatient acute care settings. So there's certainly a lot less evidence when it comes to patients having mental health disorders in the ICU setting. So this paper kind of looks at that. So the study question was the prevalence and impact of pre-existing mental health disorders in critically ill patients. And their primary outcome was the prevalence rate of pre-existing mental health disorders in ICU patients. Secondary outcomes, prevalence of these subtypes of mental health disorders and the association of pre-existing mental health disorders and ICU-related outcomes, which included mortality, length of stay, and need for invasive ventilation. So a little bit of background, a third of general community at some point in time have a mental health disorder. And certainly kind of this was talked about earlier in the morning, increased rates of physical comorbidities and premature mortality, increased rates of inpatient emergency primary care health service usage. And these patients typically do have greater lengths of stay compared to patients who don't have mental health disorders. So the study type was a retrospective cohort study. So what they did was something really novel. They used natural language processing techniques, and I'll kind of talk to you what that really means. And basically, looked into the electronic ICU progress notes and looked for the language, not really the ICD codes, which are used more commonly. And they did some internal validation with their manual chart review, and they found out this natural language processing techniques had a much higher uh, sensitivity and specificity when it comes to and accuracy when it comes to just going by the ICD codes that are documented in the patient notes. So the setting, it is not in the US. The study was done in Australia at public hospitals there. It was a mix of rural, regional, metropolitan hospitals, including tertiary and quaternary referral centers. There were about 16,000 eligible patients in the calendar year of 2019. And the participants were first episode ICU care during each hospitalization. And there were really no restrictions when it comes to age, admitting diagnosis, or the ICU length of stay. And the follow-up was for the duration of the index hospitalization. So this is a figure that they had in the paper. So what it really kind of shows is that, with the natural language processing, the word depression can mean a lot of things. It can mean depression in a mental health context. It can mean depression in a cardiac context. So what it really does, it screens for that word and then has some classification categories of either that means it's depression or not depression, and then kind of uses this Boolean logic to see if the number, the binary number of depression is more than not depression. That means the note was talking about somebody with a mental health diagnosis. So this is how they found the patients. So the first data that to look at in this study is that the highest prevalence rate was for affective disorders, and made about half of the patients with these mental health disorders. Anxiety disorders was second, and alcohol dependence was the third. And kind of talking more about the findings, they found that in their samples, pre-existing mental health disorders were found in 31% of the patients who were admitted in the ICU. These patients tended to be a little younger, had more socioeconomic disadvantage compared to patients who didn't have a mental health diagnosis. They were admitted for a medical rather than a surgical reason. They had high rates of unplanned admission. And as I showed in the previous slide, the affective disorders was the most common subtype. And these are the arrows kind of showing what I just talked about. If you look at age, for the pre-existing mental health disorders was 59.1 years compared to patients who did not have a mental health diagnosis, which 66.9 years. More likely to be female, more likely to be having socioeconomic disadvantage. More likely to have a medical admission, unplanned admission, and more likely to have longer stay in the ICU. Other findings, they required patients with mental health disorders required high rates of invasive ventilation, had greater duration of ventilation, more likely to experience delirium. For patients with mental health diagnosis, it was 15% versus patients who didn't have it was 9%. And the duration of ventilation was a median of 29 hours for patient mental health diagnosis compared to 19 hours who didn't have those. Greater ICU length of stay, and was median of 65.6 hours for the patient's mental health diagnosis compared to 51.5 hours who didn't have those. The mortality in ICU readmission rates were not different between the two populations. So again, it's kind of showing that patients with pre-existing mental health disorders had high rates for invasive ventilation with an odds ratio of 1.42, and had higher lengths of stay, about 13% longer compared to patients who didn't have mental health disorders. So how is it relevant to the CL psychiatrists? And this is something that we see very commonly, that patients who do have a mental health disorder, they do have higher complications. They stay in the ICU longer, had high rates of ventilation. And some of that could be, a lot of other confounding variables, that these patients generally have higher physical comorbidities. They did control for those, but sometimes you can't really control for all of these. And this happens very commonly, I'm sure, to everyone, that when patients are on multitude of psychiatric medications, sometimes they get stopped when the person, gets to the ICU, or patients was not compliant with the medications and they just went by the home medication list and got started on multitude of psychiatric medications that they were not taking, or were dated, or they were not compliant with, and that certainly can drive that increased length of stay and drive some of the risk of delirium. The third point could be that patients with depression and anxiety may not be as engaged or motivated when it comes to weaning off the vent or working with physical therapy and stuff to get out of the ICU. So there's certainly a lot of things that we can do to get these patients out of the ICU quicker, would be to address the anxiety and motivation, and to engage in early mobilization. Maintaining access to home psychotropic regimens is appropriate. Preventing, diagnosing, and effectively managing delirium, which I'm sure we're going to hear a lot about during this conference. And managing agitation in the peri-extubation phase. Pre-existing mental health disorders are certainly known to be a risk factor for post-intensive care syndrome, where patients can have multitude of cognitive, emotional, physical symptoms, and it's certainly important to address those once these patients leave the ICU and leave the hospital. So a few of the weaknesses when it comes to this, the study, again, the diagnosis really was based on what was in the progress notes, and were based on patient or proxy self-reporting. And there certainly needs to be external validation of the natural language processing algorithm that they used. There was no indication for invasive ventilation. That was documented why these patients actually ended up being on the vent, and they didn't have any long-term outcomes once these patients left the ICU. So the next study is an honorable mention. Again, this was supposed to be presented by Dr. Close, who's not here. And I was reading this article on my way here. It's 43 pages, but it's really, really good. So highly urge you to read on your flight back. So it's the evidence-based consensus guidelines for the management of catatonia, recommendations from the British Association for Psychopharmacology. And this was published in the Journal of Psychopharmacology earlier this year. And again, it's a long article, but a very, very good read for those of us who see catatonia quite often in the medical settings. And again, we all know it's hard to do randomized placebo-controlled trials in this patient population. So a lot of data comes from case reports, case series. So it was really, what they used to develop this consensus guideline. And they used as many systematic reviews, primary literature that they could find. And they offered a number of recommendations for with the varying degrees of strength. And they talked about some of the subtypes of catatonia, if you will, and some of the complexities when it comes to the patient population. For example, periodic catatonia, malignant catatonia, NMS, antipsychotic-induced catatonia, children, adolescents, older adults, women in the perinatal period, patients with ASD. So these are complex patient populations. So this guideline does provide guidance in what to do in these individuals who present with catatonia. An obvious limitation for something like this is there was a lack of high-powered clinical trials. So recommendations are informed by smaller observational studies and really kind of this consensus guideline document. So a few of the important things that had the highest strength recommendations was the definition of catatonia. Is that something that should be diagnosed based on the presence of 3 or more catatonic signs via the DSM-5 or the ICD-11? And if you're concerned somebody has catatonia, there's a diagnostic challenge using lorazepam should be considered. And in suspected confirmed cases of catatonia, lorazepam challenge may be used to predict further response to benzodiazepines. And in patients where benzodiazepines have not resulted in remission, ECT should be used in that patient population. They go into a lot of details about some of the second, third, fourth line treatments, including NMD antagonists, anticonvulsants, even antipsychotics, and kind of cite multiple case studies and on those. So certainly can guide you in situations where benzodiazepines don't work, ECT doesn't work, or those things are not available, or those things are contraindicated. Recommendations in kidney and liver disease and mild to moderate hepatic and renal impairment. Lorazepam dosing does not usually need to be altered, but caution does need to be exercised when considering lorazepam and severe hepatic impairment. That's all I have. Thank you.
Hi, everyone. I'm Lilia Gershengorn, and fully aware my next, I'll be presenting 3 more studies, and my presentation is the only thing that stands between you and lunch, so just hang tight. So first study, haloperidol for the treatment of delirium in the ICU patients. So this study was also named Agents Intervening Against Delirium in the Intensive Care Unit 8 ICU trial. In case you forgot the definition of delirium, we have it here. It affects about 30 to 50% of ICU patients. Most common sign of acute brain dysfunction in critically ill patients. And haloperidol is the most frequently used agent for delirium treatment in ICU, used in about 50% of ICU patients with delirium. But it's really not supported by clinical guidelines due to limited evidence. And only 1 placebo-controlled trial found in a systematic review. So this trial, the 8 ICU trial, the primary outcome was haloperidol's effectiveness in increasing days alive and out of the hospital compared to placebo. They also looked at serious adverse reactions in the haloperidol versus placebo groups. So in the study, patients received either IV Haldol, 2.5 milligrams, or placebo, which was isotonic saline. And it was administered 3 times daily. Additional doses, clinicians could give extra doses as needed. However, maximum daily dose was 20 milligrams of haloperidol, 4 ml of placebo. They were also allowed to give rescue medications. So for severe delirium, they could give propofol, benzodiazepines, or alpha-2 agonists. Patients were screened twice daily using CAM-ICU or ICD-SC, and treatment was paused if no delirium was detected, and resumed if delirium reoccurred. So during the intervention period, from the randomization to ICU discharge, death maximum of 90 days. This is the time frame that they looked at, and also looked at if the patients were readmitted with delirium within 90 days, and if they were, treatment was resumed. Other antipsychotic drugs were not allowed to be used, but all other treatments could be done at clinician's discretion at the time. So here we see the results. In the haloperidol group, the mean daily dose was about 8 milligrams, and the duration was about 3.6 days when the patients received the haloperidol. In the placebo group, the median daily dose equivalent to about 9 milligrams, and the duration was also about 3 days. What they observed was both groups received a similar cumulative dose, and the amount administered as needed was comparable between the 2 groups. In the haloperidol group, about 36% of patients died. In the placebo group, about 43% patients died. So the key results, there's really no significant difference observed at 90 days between the haloperidol group and the placebo group. Now, when we compare this study to the MIND USA trial, the MIND USA trial was the study published in 2018 looking at haloperidol, ziprasidone, and placebo with similar primary outcome. Both trials found no significant difference in days alive without delirium or coma, or in 90-day mortality between haloperidol and placebo groups. There were few events reported in the haloperidol group in both studies. with respect to mortality rate, potential suggestion of lower mortality rate with haloperidol compared to placebo, but the results remain inconclusive. The way this study differed from the MIND USA trial was this study had a larger sample size, ensuring kind of more robust findings, a broader inclusion criteria, and more patients in this study were diagnosed with hyperactive delirium, providing a more comprehensive view of the condition spectrum. So again, looking at the study, some of the strengths, this is a blinded placebo-controlled design, large sample size, high level of data completeness, and use of validated diagnostic tools for delirium assessment. Broad patient population. With respect to limitations, there's a limited number of international patients. There's a chance that some eligible patients could have been missed, and there's lack of data on use of other sedatives, pain medications, or interventions. And 13% of the trial population were exposed to open label antipsychotic agents after they withdrew consent from participating in the trial. The next study looks at the efficacy, safety, and tolerability of antidepressants for pain in adults. This is an overview of systematic reviews. So what do we know about chronic pain? Chronic pain affects about 1 in 5 globally, commonly due to musculoskeletal conditions, headaches, visceral pain. Current treatments include acetaminophen. Efficacy is not really kind of certain in a lot of these conditions. NSAIDs, known to kind of have some limited benefit, a lot of risks, and opioids prescribed to 1/3 of patients with chronic non-cancer pain, and as we know, limited benefits with significant harms. Antidepressants are now increasingly prescribed for pain, 9% in Canada, about 12% for back pain in Portugal. And chronic pain is a leading reason for antidepressant prescriptions among the elderly. So according to the 2021 National Institute for Health and Care Excellent Guidelines, really recommends against most pain medicines for chronic primary pain, but does support the use of antidepressants. So this study looked at kind of providing an updated overview on the efficacy, safety, and tolerability of antidepressants for various pain conditions. Data was extracted by and reviewed independently by 2 reviewers. Main outcome, again, pain. For headache disorders, it was frequency of pain. Continuous pain outcome scale from 0, no pain, to 100, worse pain. And data taken from time point closest to the end of treatment, as reported in the studies that they looked at, or from most consistent outcome time point across trials. Secondary outcomes included safety and tolerability. And the way they classified the findings, and I'll show you a whole slew of charts, really interesting to look at, were based on, if the findings were, if the antidepressants were efficacious, not efficacious, or inconclusive. To assess the strength of the evidence in the studies that they looked at, they utilized the grading of recommendations, assessment, development, and evaluations framework. So very, very busy table, but you can see at the top, let's see if I can use the pointer. Well, that was not supposed to happen. Okay. All right, well, I tried. So they looked at 26 studies. And you can see, if you look at the column with the conditions, so a variety of conditions, post-op pain, back pain, for example, burning mouth syndrome, functional dyspepsia. I'm not going to read all of this, but a lot of the common ones, for example, fibromyalgia, chronic migraine, tension-type headaches, neuropathic pain, non-cardiac chest pain, rheumatoid arthritis, etc. So the antidepressants that were found to be efficacious within the SNRI group on the top, so you see primarily kind of studies that looked at duloxetine, venlafaxine, commonly used SNRIs. They were found to have efficacy for back pain, post-op pain, fibromyalgia, and neuropathic pain. Aromatase inhibitor therapy induced pain in breast cancer and depression, and comorbid chronic pain, as well as knee osteoarthritis. However, if you look all the way at the column to the right, you see the certainty of evidence. Some studies have kind of a moderate, so okay, we believe the certainty of the evidence produced in the studies. But as you see kind of going down, majority of the studies kind of have low certainty of evidence. So even though they showed that the medication is effective, some may not have been done as well as others. With SSRIs, paroxetine, they looked studies with paroxetine, fluoxetine, escitalopram, efficacy in depression and comorbid pain, tricyclics in IBS, neuropathic pain, and chronic tension type headaches. Antidepressants that were not efficacious. So with SSRIs, you see paroxetine, fluoxetine, citalopram. There's one study that included venlafaxine, but it's under the SSRI category here. Sertraline did not have much efficacy in studies looking at back pain, fibromyalgia, functional dyspepsia, non-cardiac chest pain. In terms of tricyclics, they did not have much efficacy treatment of functional dyspepsia. And the rest of the studies were pretty inconclusive. So kind of hard to say whether or not the antidepressants that were used have much efficacy. So for example, looking at the SNRIs and the treatment of atypical chronic orofacial pain, chronic migraine, sciatica, chronic tension type headaches, inconclusive results pertaining to venlafaxine, duloxetine, et cetera. Similarly, for SSRIs, looking at conditions such as chronic pelvic pain, irritable bowel syndrome, chronic migraine, post-op pain, and the medications that were used also inconclusive. And there's more. With tricyclics, again, this is still inconclusive evidence for use in pain. So within the tricyclic category, inconclusive for oral mucositis, back pain, bladder pain syndrome, fibromyalgia, rheumatoid arthritis, sciatica, etc. There were also studies looking at other types of antidepressants. However, the results were still inconclusive. So looking at bupropion for back pain, trazodone, mirtazapine for back pain, fibromyalgia, still inconclusive. So there is a rise in antidepressant use, about twofold increase from 2000 to 2015. A significant factor is the off-label prescription for these drugs for pain management. In Canada, about 29% of antidepressant prescriptions were off-label. About 26 of these off-label prescriptions were for conditions like pain, fibromyalgia, headaches, etc. The approved uses, antidepressants have limited approved uses for pain conditions. In UK and Australia, duloxetine is only approved for diabetic neuropathic pain. In the US, duloxetine is approved for fibromyalgia and chronic musculoskeletal pain. And amitriptyline is approved in the UK for neuropathic pain and headache prevention, but has no approved pain indications in Australia. So the recommendations are quite variable across countries. Tricyclics are the most commonly used off-label antidepressants prescribed for pain. But a study found that about 74% of antidepressant prescriptions for pain were tricyclics. However, of the 14 conditions for which tricyclics were prescribed, efficacy was found for only 3. And the studies that I showed kind of were with low certainty. So what are some of the implications and recommendations for future research? We know about 45% of trials had industry ties, and obviously that can be bias-inducing. This is especially relevant for SNRIs, where about 68% of trials had industry ties. And the older trials, looking at tricyclics, might have overestimated treatment effects. So it's unclear if observed effects of antidepressants are clinically significant. We know that SNRIs showed less than 10% reduction on a 0 to 100% pain scale for certain conditions. So with future research, it would be important to look at different conditions that lack strong evidence-based and perform high-quality trials without the industry ties and bias. The next study was reviewed by Dr. Close, who again could not be here, so I will go over her slides. This paper looked at the association of Black race with physical and chemical restraint use among patients undergoing emergency psychiatric evaluation. So we know racial disparities exist for Black patients compared to white patients. For example, in outpatient psychiatry, there's reduced access to psychotropic medication, fewer outpatient mental health appointments. In emergency departments, there are longer wait times, less likely to be admitted, less likely to receive blood tests, other procedures, less analgesic medication, more likely to experience in-hospital death after their ED visits. And few studies have examined disparities in emergency psychiatric care. So there's a pediatric paper in 2021 that shows disproportionate chemical restraint use for Black patients. This study was a single center study at Duke, looking at data, EHR data from 2014 to 2020, included patients older than 18 who received a psychiatric consult during their ED visit. The primary outcome is record of violent behavioral physical restraint order, and also a record of chemical restraint administration, specifically looking at non-long-acting parenteral formulation of a first or second generation antipsychotic. They used a logistic regression model to evaluate the association between race and primary outcomes and adjusted for potential confounders, including age, sex, ethnicity, height, day of time, urine drug screen, peak alcohol concentration, and the diagnosis. So they looked at about 13,000 unique emergency psychiatric encounters. Median patient age was about 37. Bipolar disorder diagnosis was diagnosed at a similar rate between white and Black patients. However, psychotic disorder was at a higher proportion on Black patients. So in total, about 7% of encounters involved physical restraints, about 16% involved chemical restraints. For Black patients, physical restraints was found in 8% of encounters, chemical restraints in 18. For white patients, physical restraint was used in 5% of patients and chemical restraint in 12% of encounters. So after adjusting for potential confounders, which I mentioned earlier, the association between Black race and restraint remained. There's some limitations. This was a retrospective study based entirely on the data that they could find in the EHR, and it was a single center design. The chemical restraint was limited to parenteral antipsychotics, so they didn't include use of non-antipsychotic chemical restraints, for example, benzodiazepines, barbiturates. Reason cited was common use for alcohol withdrawal. They also did not include oral antipsychotic or sedative medications. So looking at the findings, the authors hypothesized that maybe there's a contribution from processes of both interpersonal and systemic racism that they did not measure, they could not assess in this study specifically. Disparities in access to outpatient and preventative care for Black individuals who therefore might present to care with more severe symptoms. So perhaps maybe they were coming to the emergency room, greater symptom severity. And there are disparities in Black individuals accessing mental health services through law enforcement, which might influence clinician perception of dangerousness and heighten patient stress. So for example, if they're being brought into the emergency room by police. So in conclusion, Black patients were more likely to undergo physical and chemical restraint in the emergency psychiatry setting. This only adds to the literature regarding emergency department and restraint use and extends to an intersectionality, vulnerable patients. And there is a need for further work in elucidating where the disparities arise in order to improve equity and quality of an access to care. Thank you. I think we still have time for questions. Yep.
So yeah, I think we welcome questions. I will, obviously we did not write any of these papers, so I think we're perhaps maybe, if anyone has thoughts or, a conversation they want to have, we're open to that, but please don't interrogate us about the statistical details of the papers. I promise you I cannot answer those questions.